Very good. So good afternoon, everybody, and welcome to the second webinar of the second season. As you know, these are webinars that we organize together for different Italian universities. We have the University of Torino with Professor Brazzi and Professor Caironi connected. We have the University of Ospedale San Raffaele with Professor Landoni connected. Shortly, Alberto Zanella from the University of Milan will connect, and my name is Thomas Langer. I'm from the University of Milano Bicocca. So these are webinars, as you know, on different topics in anesthesia and intensive care, and it's a real pleasure today to introduce Professor Lorenzo Berra, who is an endowed Reginald Janewy Associated Professor of Anesthesia at the Mass General Hospital, Medical Director of the Respiratory Care, and most importantly, a former student and resident of the University of Milan. So he has spent a lot of time doing research, both at Bethesda with Dr. Kolobov and subsequently with Warren Zappo in Boston. So I think that there his love for nitric oxide really started. As you heard already from Lorenzo, we have other two guests, and we're very grateful to them. Dr. Binglan Yu, PhD, staff researcher at MGH, and Dr. Ran Dong, medical doctor from the critical care physician at the Peking Union Medical College. So with this introduction, I will give the word to Lorenzo, but before that, please remember that you can ask questions at any time using the chat box. It's on the right lower corner of your screen. Just ask whatever pops up to your mind. We will ask these questions at the end of the webinar to Professor Berra and colleagues. And also, as you heard, we are recording the webinar, and it will be available later on our YouTube channel. So with that said, thank you again to everybody for being here. Thank you to Lorenzo, Binglan, and Ran to be here, and the stage is yours.
Thank you so much to everyone. And I hope you can see the screen that it displays here. So thank you again. So I wanted to talk to you today about nitric oxide, and we are going to do a little bit of a journey on nitric oxide from really biology to therapeutics. And of course, I needed to thank many of the fellows and mentors that I had throughout these years. These are some of them. You may recognize many physicians now that are back in Italy, that they spent some time here, and there are some, of course, that are still working here. So today it's gonna be a very interesting talk. I'm sure that there will be some people that will be very familiar with nitric oxide and others that are less familiar with nitric oxide. So the goal really is to go into a little bit of in a journey to talk about from the therapeutic, really from actually the discovery at the beginning, how it works, and going from really respiratory failure in the newborn to the adult. And then a little bit of research we are conducting now on the potential effects of nitric oxide as an antimicrobial. But of course, we have lots of questions ourselves. So I'm sure that we will share also many unanswered questions during our presentation. So in order to start to talk about nitric oxide, we really needed to go down and recognize the discovery of nitric oxide that was done by these three pharmacologists that discovered nitric oxide as a really natural gas transmitter that is produced by our cells. In particular was endothelial cells. Endothelial cells that regulate blood flow. and regulates cardiovascular effects. So this was really the background of the Nobel Prize that was delivered to these three pharmacologists in 1998. Really was like the idea that was the first time that a gas transmitter was recognized as a fundamental in biology, in human biology. But how do we go from really this discovery, so production, endogenous production of nitric oxide, to actual therapeutics, so the gas therapy as we use it in the intensive care unit or in the operating room. So in the late 70s, early 80s, Warren Zapol, that was a physician that passed away now 3 years ago, here at MGH, that has been the mentor of many of us. At that time, he was studying respiratory failure. And he recognized early on that pulmonary hypertension, and that there is one of the key factors and features of respiratory failure. They actually studied how pulmonary perfusion is actually injured in a respiratory failure. Studied by really contrast media as well as anatomopathology studies. We really concentrate many times on the alveolar aspect of ventilation, for example, and parenchymal injury in ARDS, but we never or we little think about the vascular effect injury in ARDS. He was really into that. He was really interested in understanding vascular effects. And so, since he was really an anesthesiologist, he thought about what about we can maybe use this molecule that was just discovered as a vasorelaxant of the pulmonary circulation. The problem was that, in fact, nitric oxide, it was also recognized as a potent poisoning gas and a deadly gas for the human body. And so, with all the, the incredible smart interest of a new discoverer and scientist, he said, okay, maybe we can be very careful. We open all the windows and we can test this gas in an animal model. So he took a sheep. So this was the first study demonstrating inhaled nitric oxide as a pulmonary vasodilator. So together with Klaus Frostel in 1991, they basically took this sheep. They introduced a pulmonary artery catheter. They were able to measure the left atrial pressure, pulmonary artery pressure, as well as an arterial line to measure systemic artery pressure and cardiac output. Then what they did was to develop pulmonary hypertension by injecting a pulmonary vasoconstrictor, and then starting to deliver nitric oxide at 80 parts per million. 80 parts per million, it means that if you take a volume of one entire volume and you divide it in 1 million parts, so only 80 parts, so extremely very, very little concentration of nitric oxide was delivered to the lungs in these animals. And what you see, in fact, that there was a reduction of pulmonary pressures, and then when the gas was stopped, then the pulmonary pressure goes up again. So it was actually the first demonstration that inhaled nitric oxide is a selective pulmonary vasodilator. As you can see that the systemic arterial pressure didn't change. So was able to selectively lower the blood pressure in the pulmonary circulation, but actually remained normal in the arterial circulation. That was 1991. And immediately, as he was not only a great innovator, but a great he liked really to translate science that he was finding in the laboratory, in the clinical practice. A year later, in 1992, in Lancet, J. Roberts, he actually tested the gas in newborns, specifically patients that had pulmonary hypertension of the newborn. And what you see here is that the oxygenation in all these children, there were like 8 children, the newborns, the oxygenation improved immediately. That was the first demonstration that, in fact, the nitric oxide not only is actually effective a pulmonary vasodilator, but also that was safe to give it. And that was the first gas tank that you see here. Then after that, in 92, this was 92, 93, on the New England Journal of Medicine, the group together with Rol Rassan, what they did was to do a study in which what they did was an on-off-on test of nitric oxide in patients with ARDS. These were 10 patients, and you can see that basically nitric oxide is started and then is actually transiently stopped, and so the pulmonary pressure goes up, and then the nitric oxide is returned, so is actually turned on again. And so you can see that there is an on-off-on effect. So there is a pulmonary hypertension when the gas is stopped. That again demonstrated that the gas is a pulmonary vasodilator, but also when they measure shunt fraction into the lungs and oxygenation into the lungs, what they found was that, and that was the second feature of nitric oxide, is that nitric oxide is a selective pulmonary, it's a reduced intrapulmonary shunt, therefore improves VQ matching. That's the reason why nitric oxide is used in ARDS patients. So because improve VQ matching. So, but let's think about and take a step back and try to understand how and what are the mechanisms by which nitric oxide works. So this is like a nice review that Fumito Kinosi wrote now 20 years ago on circulation, but is really very, very practical in terms of the mechanism. Nitric oxide, when it's inhaled, diffuses immediately through the alveolar-capillary membrane and activate soluble guanylate cyclase. When it's activated, then there is a conversion of a GTP in CGMP, which is responsible for the muscle, the smooth muscle relaxation. And then the CGMP is converted and hydrolyzed to GMP by phosphodiesterase. So there are two mechanisms by which you can increase vasorelaxation. Either you inhibit the phosphodiesterase or you increase the actual amount of nitric oxide. Both things can actually potentiate each other if you do the two things combined. So going back to now ARDS. So I showed you the first study from 91 to 96. They were the first studies, discovery, and actually the first evaluation in humans on nitric oxide. But the first trial in ARDS patients came out in 2004. The first trial was a randomized clinical trial in the United States. They were randomized 386 patients. The concentration of nitric oxide that was used was 5 parts per million, and I underlined to you the concentration also is very important. So it's 5 parts per million, different from what was used before, 80 parts per million, so even a smaller amount. And what they found was that despite nitric oxide improved oxygenation in the first 12 hours, By 24 hours, the nitric oxide, the group that was randomized to nitric oxide actually was reduced to basically not having any changes or any difference between the two groups by 48 hours from the starting of the gas. But more importantly, there was no effect, no improvement in any outcomes in those patients that received nitric oxide. So it was a negative trial with just a short improvement of oxygenation in the first 12 to 24 hours. So that's the reason why since then nitric oxide has been really left to those patients that are very hypoxic when nothing really works. But if you look in the literature, what you find is that until 2023, all the trials that have been done on nitric oxide in ARDS, they were before the trial on protective lung ventilation. So in 2000 there was the large trial, the ARTSNet. However, those studies included the one in 2004. The normal tidal volumes were 12, anything that was between 10 and 14 cc per kilo. So what we did was in 2023, we actually did perform the randomized clinical trial during COVID. So this one is the trial that I'm going to talk to you about. Raffaele Difenza, that he led this trial. But then I will also mention the experience from the Mayo Clinic that was published in the same year. So first, the trial that we performed, this was a randomized multi-center clinical trial. 200 patients were randomized in the study. 100 were assigned to control, which is a standard of care without nitric oxide, and the other 100 patients were received nitric oxide. What you see here is a density plot, which means that there is the amount of improvement in oxygenation in between the two groups. So that means that the entire curve is shifted to the right, meaning that all patients that receive nitric oxide improve oxygenation at about 35 millimeter of mercury after 48 hours since the gas was started. As you can see, that if you stratify by severity of hypoxemia, there is an improvement in oxygenation in those patients that are more hypoxic. But just to underline the difference with the previous trial that only show improvement in oxygenation during the first 24 hours, we used 80 parts per million. So we went back to the higher dose of nitric oxide. For mortality, you can see here that there are two curves, one at 28 days survival and 90 days. There is an increased likelihood of survival on those patients that received nitric oxide, so the curve is shifted to the left. It's not statistically significant, but clearly there is an improvement in terms of likelihood of survival. For secondary endpoints, they were negative besides the neurological outcome. So there was an improvement in neurological outcomes at 90 days in those patients that received nitric oxide. So there was an improvement in motor and sensory. So there were more deficits in those patients that did not receive nitric oxide. And as an additional result that we were very surprised to find was that there was a clearance of the virus in the sputum and in the blood that was much faster in those patients that received nitric oxide. So the gas was acted as a virucidal in these patients. And this is something that I'm going to go back in the presentation later, and I will explain what we found and why. So in conclusion, for this first trial and first setting of a study, I think that what the nitric oxide showed is that if nitric oxide is given very early at 80 parts per million, and the concentration is not changed for the first 48 hours, there is not only an improvement in oxygenation, but there is an improvement in the likelihood of survival that didn't show a reduction in overall mortality, but there was also a reduction in neurological outcomes, and specifically was also safe to use. But we had also comparing some questions, also comparing to previous literature. So we know that so the difference between the previous studies, as I mentioned to you, is that we deliver the gas from the get-go. We didn't wait until the patient had the ARDS. As soon as the patient was intubated for respiratory failure, we actually randomized the patient to, as soon as we get the consent, within the first 48 hours from intubation. We use a high dose, 80 parts per million. We don't know, however, whether what patients are most sensitive and susceptible to a high dose nitric oxide. Possibly by acting as an antiviral, it's very important to give it at early on in the therapy. And then also very clearly, one of the things that is very different from prior studies that we adopted protective lung ventilation in terms of volumes, in terms of pressures, and we try to ventilate the patients within the 10 to 14 range of driving pressures. And last, I think there is one aspect that is extremely interesting to us is that we recognize the patients that have COVID-19 had an endothelial dysfunction due to the viral infection. And so we actually kind of reasoned on whether those patients that have more endothelial dysfunction, so they are unable to produce nitric oxide, they are probably maybe more sensitive to the therapy. So what we looked in the literature is well known that patients with black patients compared to whites, they have actually developed an endothelial dysfunction earlier. And so also patients, of course, with diabetes, hypertension, and obesity. So what we did in a post-hoc analysis was to actually select and differentiate outcomes by race. So we had black patients and white patients, and we divided and we look for outcomes. And what we found was that not only the black population improved much more in terms of oxygenation compared to the whites, but also that the mortality was actually reduced in the black population at 28 days and 90 days, which became significant. The last study that I want to talk to you about in use of nitric oxide in ARDS is the experience from the Mayo Clinic. This is not a randomized clinical trial. However, the Mayo Clinic, what they did was to collect all the data that all the patients that they use nitric oxide, whether intubated or not intubated, across all their institutions, so including Arizona, Florida, and in addition to Rochester, Minnesota. What they found was that they actually look for mortality improvement. There was not improvement in mortality in those patients that were mechanically ventilated when nitric oxide was added late. So this is a late use of nitric oxide in those patients with ARDS. However, there was an improvement of survival in those patients in which nitric oxide was used at early onset. So when there was still used non-invasive ventilation or high flow ventilation. So in conclusion from this area of research in ARDS, I think that there are many questions that remain open. There is more studies that need to be done. However, for our experience, when nitric oxide is given early at high dose and according to lung protective ventilation, we found that nitric oxide is safe. There is not increase in renal replacement therapy or AKI, improves and sustain oxygenation, reduce neurological symptoms, improves survival in non-intubated patients and in self-reported blacks, and might act as an antimicrobial. And so now let's shift gear and talk about antimicrobials. So this is an area of research still. So here we tried to summarize a little bit the effects of nitric oxide in the lungs. And so I talked to you about selective pulmonary vasodilator and ventilator perfusion matching. And I also added some dose, so just to have an idea. You can use a nitric oxide to produce a selective pulmonary vasodilation, and the response is dose dependent. If you give a 20 parts per million, it will be different if you give a 80 parts per million. The higher dose you use it, the more vasodilation is produced in the lungs. However, if you wanted to improve oxygenation and you want to use a ventilation perfusion matching, then you need really to use a low dose. There are groups in France and Germany, for example, that they use like 0.5 parts per million to 5 parts per million, because there is the lower concentration you use, there has been studies that show actually an improvement in VQ matching, which is lost at very high concentration of nitric oxide, because there is a vasodilation that is not selected anymore into the lungs. I'm not going to talk about a bronchodilator, anti-inflammatory, and antithrombotic effects of nitric oxide. However, there is lots of literature, and there is some of the concentration that I leave you here, so just to have an idea. I'm going to concentrate now in this part of my presentation on antimicrobial effects of nitric oxide, which is actually what, when we talk about antimicrobial effect, we need to think about concentration that are much higher than what generally is used, so much more than 40 or much more than 80 parts per million. We use it up to 300 parts per million. But let's think about nitric oxide in biology. Why nitric oxide is an antimicrobial? Well, nitric oxide is used by our cells, by macrophages, neutrophils, as one of the two major antimicrobial pathways to kill bugs. So you have ROS, reactive oxygen species, and reactive nitrogen species. These are the two pathways by which we actually kill bacteria. So it's not really a surprise. Our human biology for millions and millions of years use these pathways. So it's not surprise. What we need to study is not to demonstrate that nitric oxide is bactericidal or virucidal. What we need to demonstrate is that what is the concentration to which nitric oxide becomes antibacterial? What is the safe concentration that we need to give it? How to deliver it, and for how long, like in an antibiotic, for let's say, how long do you need to deliver it? So this is the area in which the structure, mental structure, that we actually face this problem. In 2020, this was the first study that was done in the laboratory with Dr. Zepo. This is Stefan Wiegand, that what he did here, he took Klebsiella pneumonia, and what he did was to do a culture of Klebsiella pneumonia and using scanning electron microscopy. You have a control here. And then what he did was to increase the concentration in a media of a nitric oxide donor. It's called the Nano8. What it is, basically, it's a nitric oxide donor. So when you put it in the media in contact with with Klebsiella is released the nitric oxide. And you can see that there is an increased bactericidal effect by concentration. So at 10 micromoles of nano-8, the Klebsiella pneumonia, the membranes are destroyed and dissolved. And what he did was then, okay, now this is in media, how about if we deliver it in gas? So he took some mice and challenged the mice, the lungs of the mice, with the same Klebsiella pneumonia that he tested in vitro. And these are concentration of the bugs into the homogenized lungs at the end of the experiment. When he used a continuous concentration of nitric oxide at 80 parts per million, as you can see, there was no difference between the controls that are white in white dots versus the triangles. So there is no difference between the two in terms of concentration of Klebsiella in the lungs. However, when the concentration was increased to 160 parts per million, there was a trend in the reduction. At 200 parts per million, there was clearly a difference of 2 logs between the two groups. At 300 parts per million, there was even animals, some mice that didn't have any bacteria into the homogenized lungs. And not only, they had to use intermittent concentration, so it was not delivered continuously, but also the lungs, as you can see, there was not injury. There was no lung injury due to the high dose, high concentration of nitric oxide. So while we were doing this experiment, a great friend of ours from the lab as well, Ryan Carroll, is a pediatric ICU physician that works with us in the laboratory and like me is a physician at the hospital. He was taking care of a patient. And this was the case of Courtney. Courtney at that time was 16 years old. Now he's 21, actually 22 years old, and has a cystic fibrosis. At that time, I was very sick, was hospitalized with Pseudomonas aeruginosa and Burkholderia cepacia in the sputum, which was a multi-resistant bug. And they were trying every possible antibiotics, but however, the Burkholderia specifically was resistant to all those bacterial, to those antibiotics. But now I have a video, which I hope you can hear it from her, explaining what happened to her. I think it's much better than me trying to explain to you. Let me start the video and you let me know if you can hear it.
Unfortunately, we don't hear it, Lorenzo.
Ah, okay. Sorry. So then I will skip it. Courtney, basically what, and maybe I can show you something. Let me in the video if there is a no, that's okay. Never mind. So what we did was what she did was to deliver. Maybe I can show you. What I can show you is the delivery device. So let's see. Okay, here it is. So what we did was to deliver a high dose nitric oxide to her in a concentration up to 250 to the max, to reach the max of 300 parts per million. And what was impressive to see was the reduction in terms of antibiotic resistance of the Burkholderia. And the beauty, of course, is that she could go home and start to use other antibiotics that she could take PO, so Peros, different than the IV antibiotics. She's coming back from time to time to the hospital again, still, and she still requires some hospitalization, some treatments. But as you can see, We have been giving to her more than 200 treatments over the past years, and she's been tolerating very well, and she's doing relatively okay. That was really our first experience, which actually led to, during COVID and after COVID, to multiple trials and studies. I actually listed here, I'm not going to go over all of them. So there are more than 12 publications where we actually used nitric oxide at 160 to 300 parts per million, which was very well safe and well tolerated, where improved oxygenation and reduced respiratory rate in these patients. And we tested also in pregnant patients, meaning that there were, at that time, there was no other therapy that was approved for pregnant patients. And so we actually used nitric oxide for them. And in fact, it reduced not only the shortened ICU hospitalization and shortened supplementation of oxygen in those patients. A study that was just published from the Australian group, this is a study that came out in July this year. Actually, it's very nice because it's confirming some of the study that we found, so it's independent from our center. What they did was to deliver nitric oxide up to 250, 300, actually not peaking at 300 parts per million, on patients with Mycobacterium avium complex. So there were patients that were home at the beginning at the hospital, but eventually they went home and they could be treated with this high concentration even at home. And there was a reduction of the bacterial concentration in the sputum. We have been just approved to start now a treatment and a randomized trial in ICU patients with pneumonia, with bacterial pneumonia at INO 300. And this is something that I hope that by next year will be completed, and we'll be sharing some of these results. So in summary, I think that it's very important to, this is an area of a great expansion, but again, we are not yet understood and know what is the concentration that needs to be used, but there are first studies that are promising in terms of antibacterial, antiviral effects. But that led also to changes and innovation from a technological point of view. Unfortunately, I'm not gonna show you this wonderful video from Dr. Zapol that it's not, of course, we cannot show you, but we will. I'll go over and I let Bingla you to talk about the second part of this presentation.
Good afternoon. My name is Binglan Yu. I'm working with Dr. Berra. In the following few slides, I'm going to talk about nitric oxide, how it is delivered, and also the recent development in the NO generation and delivery systems. So this is a slide to show you the conventional NO tank, which you can see is bulky and requiring distribution network, storage space, and trained respiratory staff. And also the NO therapy is quite expensive. For 5 days to treat a PPN patient, it's approximately about $14,000. So to solve this problem, we proposed to generate nitric oxide from air using pulsed electrical discharge. You can see the slides here. The plasma, the electric arc form between high voltage tip and ground electrode. The temperature of this plasma can reach 1,000 degrees Celsius, and the nitrogen and oxygen in the air under this high temperature reacts and produce nitric oxide and also other nitrogen derivatives. So this is, we developed two prototypes in NO generators in our lab. The left panel shows the benchtop NO generator, which weighs about 4 kilograms, and the right panel shows the so-called inline NO generator, which is only about 2 kilograms. You can install it in the inspiratory limb and deliver to a subject. And then we tested this electrically generated NO and to see if it's equivalent to the NO diluted from a conventional tank. So in large animal sheep, we measure pulmonary arterial pressure. At baseline, it's about 13-14 millimeter mercury. And then we give a U46619, which is a potent vasoconstrictor to increase PA pressure to about 30 millimeter mercury. And then we give NO to the sheep. So within a minute, you can see it decreased the PA pressure immediately. And then once we stop the NO delivery, you can see the PA pressure went up. We also compared the NO diluted from the conventional NO tank shows in the purple line, and there was no difference. So the right panel shows the PVR index, also inhalation of NO reduce PVRI. And then with Dr. Berra, we conducted a human trial. We had two groups. So first group is the healthy subjects. We gave them 20 ppm of NO for 10 minutes. We can see the subjects holding the so-called fluid device to breathe NO. And then we recruited 6 patients with chronic pulmonary hypertension. So for the left panel, you can show the black bars shows before NO delivery, and then the white bar shows the mean pulmonary arterial pressure during INO delivery. The first group is we deliver NO through the conventional NO tank. The second group was NO was delivered from our electrically generated electrical NO generator continuously, and the third group NO was delivered from our electrical NO generator intermittently, meaning the patient only get NO during inspiration. And the right panel shows the mean PA pressure in each patient before NO delivery and during NO delivery. So we can clearly see the results. INO reduce mean pulmonary arterial pressure. And then we developed in our lab a so-called miniaturized NO generator. So weighs about only 14 grams. The left panel shows this is the metal part is the NO generator. And then we have airflow tube to provide air into the NO the chamber. And then we can install it into the airway connector to deliver to the subject. The right panel just show you the NO generator chamber. We have the top right chamber is the NO2 scavenger, which only weighs about less than 1 gram. And then we tested this miniaturized NO generator in a rabbit, which weighs about 3 kilo to mimic the newborn. We use RVSP as a surrogate to mean pulmonary arterial pressure. We find at baseline it was 13-14 millimeter mercury, and then we use U46619 to increase RVSP, and then we can see the inhalation of NO immediately decreased RVSP within a minute. And again, once we stop NO delivery, the RVSP went up. Okay, and also we monitor the NO2 levels. while we give NO at 80 ppm. So the NO2 level remained below 1 ppm up to 48 hours, which is the US EPA level safety threshold. So indicating we need to change the NO2 scavenger, the top white part, every 48 hours. We also measure ozone levels when we deliver 20 ppm, 40 ppm, and 80 ppm of NO. And we find the highest ozone level was around 3 ppb, which is well below the US EPA level, 80 ppb for the safety threshold. This is just show you our mentor, Dr. Lorenzo, wearing the portable NO generator. So you can see it's all in this box. And then I like to introduce a couple newly developed NO generators in our lab. So first we call high pressure NO generator. We all know it's the higher the pressure for the NO chamber, the higher NO will be produced. So we use from 1.5 atmosphere pressure to up to 3 atm to improve NO production. Up to for this device, we can generate up to 200 ppm. And then the middle device we call a double spark plug NO generator. We put 2 NO generation chamber in a line, and then to double the NO production. And the last panel shows you that we use a gliding arc technology to increase NO production. You can see. So you can see the arc going from the narrow gap to the wider gap. So the wider of the gap, the higher of the NO will be produced. So this is the last slide. I'm going to show you a couple of tankless NO generators available in US. So first one is the Vero Biotech, which received FDA approval about 2 years ago. So the how they make NO production. So they use a chemical reaction. They convert N2O4 into nitrogen dioxide and NO2, and then convert NO2 further to NO using ascorbic acid cartridge. And then there's another company called Beyond Air in US, received FDA approval about 3 years ago. They use a quite similar technology using a plasma arc to generate NO. And then there's another, the Chinese company called Novolid, received a Chinese NMPA about 3 years ago. They use electrochemical method to convert nitrite into NO. And this is another US company called Serpol in Boston. It's a spin-off company from our lab. They have several products, the one called ENOFit, which is currently under FDA review. Thank you.
So I think it's really telling and wonderful to see that there is a technology changes, because that will also allow faster research and also care for our patients. You can imagine to use like very little devices that actually, and also inexpensive devices that can actually reach patients in many conditions, either at home or very in remote areas. But let's go back to, and I wanted to conclude with this last portion about the use of nitric oxide in cardiac surgery. Because the reality is that most of the nitric oxide that is used in the hospital nowadays is in the acute setting, is in the cardiac surgery. Mostly, of course, is going back to what we discussed before, is used because improves pulmonary vasodilation and therefore reduce right heart strain, improve VQ matching. But also, and I'm going to talk about this, that is an area that is in expansion, that there are also some effects. We always say that nitric oxide is a selective pulmonary vasodilator, but doesn't mean that there are not effects that are systemic. In fact, there are systemic effects that has been actually under validation. Really, we are studying this area of nitric oxide. Specifically, we are actually looking into the effects of nitric oxide in hemolysis. And why is that? There is this wonderful study that was done now 20 years ago by a group of Minnici and Mark Gladwin. What they did was to actually deliver, infuse hemolyzed blood in plasma. And what they studied was that there was a consumption of the nitric oxide produced by our endothelium that is in 1-to-1 ratio. Therefore, if there is 1 mole of free hemoglobin, so hemolyzed blood, is going to consume 1 mole of nitric oxide produced by our vasculature, by our endothelium. What is the effect? The effect is that when there is depletion of nitric oxide, of course, there is vasoconstriction. And that's what you see. If you actually give an infusion of free hemoglobin in an animal, what you see is that there is a pulmonary vasoconstriction and systemic vasoconstriction. In this case, there was what they found and what they showed was that by infusing free water, which produce hemolysis, there was an increase in mean arterial pressure. So there was a vasoconstriction effect due to a reduction of nitric oxide in bioavailability in circulation. Not only, there was also a reduction of creatinine clearance, showing that there is an effect on the kidneys in terms of kidney injury. So what they did was to actually deliver nitric oxide in this was a study in dogs. What they did was to give free hemoglobin and then subsequently also deliver nitric oxide, and they showed that they were able to prevent some of the acute kidney injury. That was really the kind of start of the idea of that study that actually then developed a series of studies that we did in laboratory here at MGH, both in animals and then also in humans, and many of the fellows that have been here, that came from especially from the University of Milan, but also from Rome. They participated in these trials and these studies. What did we find? Just to summarize our experience, that hemolysis causes depletion of nitric oxide, and that can actually cause acute kidney injury. It's associated with acute kidney injury. And so our idea was really to deliver nitric oxide to replace the nitric oxide that has been scavenged. If you look at some of these are the picture from our collaborators. This is a picture from Chong Lei, that was a research fellow when I was also a research fellow here in the laboratory. She was sending me these pictures of blood that is clearly hemolyzed, so and the urine that is hemolyzed. These are pictures that I'm sure you see every day in cardiac surgery where you work. That was the idea to start a study. So I went to Shijing Hospital in Xi'an, and I stayed there for 4 months to initiate this trial together with Chong Lei. What we did was to deliver nitric oxide not only in the cardiopulmonary bypass, so in the operating room, directly in the machine, but also then on the ventilator in the operating room when the patient goes off cardiopulmonary bypass and goes on the ventilator, and then in the ventilator in the ICU, and or even to the in the nasal cannula when the patient is extubated. What we found was that there was, in fact, in the black dots, what you see is the study group where we deliver nitric oxide. There was absence of the consumption of nitric oxide. So we prevented the depletion of nitric oxide that is showed in the control group. That translated in a reduction of acute kidney injury, and not only acute kidney injury, but also renal injury, chronic renal injury. So, and that was the first large study that we did. Was one center, patients were randomized, and that the question, however, remained in terms of what about other patient populations, because we studied Chinese patients that had multiple rheumatic fever, rheumatic valve disease. And so the idea was what does it mean to translate it to other patient population or patients with a CKD, so that they come already with chronic kidney disease. This was a study that we did in Siberia with Nikolai. We did a similar study. Always the nitric oxide was delivered through the cardiopulmonary bypass and then to the patient on the ventilator and then extubated. What he found was that, in fact, there was a reduction of acute kidney injury in this patient population, with patients that are maybe more commonly what you see more commonly, patients with in the age around 60 and plus years old, with endothelial dysfunction, with diabetes, and already with starting with some level of CKD. Now we are running a trial in more than 3,000 patients in between China and Russia. We are at 10% of the enrollment, so there is a way to go, but it's actually working very well. However, I cannot say that I cannot actually not present this study. This is a similar concept. The authors deliver nitric oxide in the cardiopulmonary bypass for children during surgery. Only during surgery, they deliver 20 parts per million, and they deliver it only into the cardiopulmonary bypass. They did not deliver it through the ventilator. So during only the surgery, the idea was to reduce the time on the ventilator, the cardiac outcomes, and the renal outcomes. But in fact, the study was tremendously negative. As you can see, there was no changes or difference in ventilator-free days. There was no difference in any other outcome in these two patients, in the two groups, between the two groups. So it was all negative. So the question is why this study is different from our study. Certainly the patient population, because these are newborns, or children, or actually infants. But also the concentration of the gas is 20 parts per million, and it was given only for 2 hours during surgery. If you look and take the supplement figure in table 4, what you find is that the methemoglobin, that is a product of oxidized hemoglobin, was increased only 0.4%, which is a really a very low concentration in terms, if you think about the delivery of nitric oxide. And so it led us to think that not only the concentration of gas is important when we wanted to actually obtain extra pulmonary effect, but also the amount of gas that is absorbed by the patient. And so now I will ask Dr. Randong to present the last part of our presentation for the last 10 minutes, and here it is. This is her work. This is you are the first one. Oops, you are the first one to hear. Here it is.
Hello, everyone. I'm Ron. Thank you for having me here. So this part will focus on the pharmacokinetic aspect of inhaled nitric oxide when we use it as a systemic agent. And this work is actually completed by a team of basic scientists, engineer, data scientists, and physicians. When we talk about the systemic effect of inhaled nitric oxide, as any drug we use systemically, we need to know how much mole of the drug we delivered and how much is absorbed. In terms of nitric oxide, it's quite difficult to measure because its half-life in the blood, it's extremely short. It's 0.5 microseconds. And this picture shows what happens when nitric oxide cross the alveoli and
I'm sorry to
enters the
interrupt.
blood.
Sorry, we're not seeing the slides. Sorry for the interruption. Could you please share your screen?
Yeah.
Thank you.
Okay, can you see?
Yes, thank you. Thank you so much.
Sorry.
Yeah, so this picture shows what happens when nitric oxide crosses the boundary between alveoli and the blood vessel. And once it enters the blood, most of the nitric oxide will combine with with hemoglobin to form methemoglobin, and a lesser part will will combine with other proteins. So this makes us think that methemoglobin is not only a safety parameter of inhaled nitric oxide, it can be used as a marker of how much the gas is absorbed. And actually this idea was generated also like 30 years ago by a British anesthesiologist. He actually modeled the kinetic of methemoglobin during inhalation of nitric oxide at 4 different doses. And on the right panel, we can see that at the 4 different doses, there's a different kinetics of methemoglobin elevation. On the lower right panel, we can see that after stopping the gas, the methemoglobin eliminates following the first order kinetics. And this process is actually mediated by the methemoglobin reductase. And in our study, we also found that the dose you delivered, that's in parts per million, it's a volumetric dose. It doesn't necessarily equal to how much the patient absorbed. And this is the healthy subject study who received inhaled nitric oxide at 300 parts per million for 30 minutes, 3 times per day. These subjects received the gas on day 1 to day 4 when they were at rest. And on day 5, we put them onto the stationary bicycling and while receiving the gas. And on the right panel, we can see that they have quite different levels of methemoglobin. And the orange one, it's when the subject it's receiving the gas at exercise. And the blue one, it's a much lower level of methemoglobin. It's when the subject it's receiving the gas at rest. And so this forms the idea of our study. First, we wanted to establish an inhaled nitric oxide absorption quantification system. And this makes us capable to measure the amount of NO absorption directly. And the other part of the study is that we use methemoglobin kinetics to estimate the amount of nitric oxide absorption, so that in the future we don't necessarily need to measure the direct absorption for every patient. We can use methemoglobin as a bedside marker to tell how much nitric oxide the patient absorbed. And the system is set up using actually it's a closed circuit. Patients are intubated, or they use a sealed mask to inhale the gas. We connected a NO analyzer. This is a rapid response one, and a pneumotachograph on the Y piece of the circuit. So these two devices will generate NO concentration, will measure NO concentration and airway flow at the same time. And we use an integration of the two measurements to calculate the volume of nitric oxide that is absorbed. And if we have the volume of nitric oxide absorbed, we can calculate the mole of nitric oxide absorbed. Then we validated this system using the gas collection bag method. So we connected the two devices to the Y piece, and at the same time we used two bag. One is the inspiration bag, the other is the expiration bag. They are separated, so the animal can only inspire NO from the inspiration bag and exhale to the expiration bag. And we can use the bag collection method to also measure how much NO the animal absorbed. So then we compare the two methods of NO absorption measurement, and found a quite good agreement between the two methods. So this actually validated that our breath by breath direct measurement of NO absorption is correct, can correctly measure how much NO we absorbed. So then we use this system to measure NO absorption in different groups of subjects. So as we can see in this figure, this is the methemoglobin level during NO treatment. And the dashed line shows, before the dashed line, the subject is receiving the gas, and the dashed line shows the time that we stop the treatment. And we can see that even at the same dose and the same subjects at different status, or the patient, they have different level of methemoglobin. And at the same time, we measured the NO absorption. They have quite different level of NO absorption. The higher the level of methemoglobin, the higher the level of absorption. So this makes us to think maybe we can model the relationship between NO absorption and methemoglobin kinetics, so that if we know the patient's kinetic of methemoglobin, which is very easy to measure at bedside, we can back calculate or estimate how much NO this patient absorbed. So this equations are probably quite complicated, but the major principle is that we incorporated NO absorption the amount of NO absorption into this equation. And we used some of the patient data to generate the model so that we get every variable in this equation. And then we use the other patients as a validation data set. In these patients, we estimated NO absorption using the methemoglobin kinetics. And at the same time, we directly measured NO absorption using our system. And we compared the two levels of NO absorption. We found that they reached quite good agreement. So this makes it possible to estimate NO absorption at BEST using methemoglobin level. And then you may be interested in what factors may contribute to the level of NO absorption. And we also did some studies on that. So we delivered the same concentration of nitric oxide to the animal and changed a single ventilatory setting and measured the NO absorption before and after the alteration of ventilatory setting. So we found that tidal volume significantly it affects the level of NO absorption. So it's quite reasonable. The higher the tidal volume, the more nitric oxide is delivered and the more the patient absorbs. And also we found that the inspiratory pulse and inspiratory time also affects the NO absorption level. And this tells us that probably the longer time that the nitric oxide get contacts with the alveoli, the more the patient can absorb. And we are still working on this part of the study. So this study, in this study, we developed the first system to measure inhaled nitric oxide absorption. And also using this system, we established a model between methemoglobin kinetics and NO absorption. This enabled us to use methemoglobin as a point of care marker for NO absorption. Thank you.
And so just as a conclusion, I think this changed completely the paradigm of nitric oxide therapy in terms of when is given. So we probably don't need only to monitor the concentration, but of course the absorption, because it's clear that the higher is the more sick is the lung, the less there will be absorption. So the redefining also the understanding of who is the responder, who's not responder, the amount of concentration, and it can become also a diagnostic analysis for patients with chronic lung disease. So with this, I just wanted to thank you, everybody. These are some of the information about who wants to learn a little bit more about nitric oxide. There is a Journal Society conference, and of course, can reach us anytime. So thank you so much.
Thank you, Lorenzo. Thank you, Ron and Binglan. This was really an outstanding webinar, and I thank you really a lot for that. We have several questions, some coming from the audience, some from the organizers. So I will start. I tried to write them down and try to give them some sort of order. And I would start with the use of nitric oxide in ARDS. So one question that came is, beyond research protocols, how do you currently use inhaled nitric oxide in your clinical practice, in ARDS patients or in other populations?
Very good question. So we have what we do is this. We have a protocol for clinical use that is based on the physician that started nitric oxide needs to say why he wants to use nitric oxide. As we discussed, nitric oxide has lots of effects, and so one has to declare why is he using it. Is he using it for pulmonary hypertension as a pulmonary vasodilator, or is he using and therefore improving for right heart function, or is using for hypoxemia? And so then the therapist, the respiratory therapist, initiate a nitric oxide, and let's say that the reason is to reduce pulmonary hypertension. Either there is a PA catheter or transthoracic echocardiography is done, and in order to say that the patient is a responder or to maintain nitric oxide, the response has to be higher than 20%, which means that the pulmonary vascular resistance or PAP or right heart function and whatever is calculated is actually improved than 20% after 1 hour from initiation. If that doesn't occur, the gas is stopped. Same thing for VQ matching. If a patient has ARDS and the gas is started for hypoxemia, then that needs to be declared and the AVG is taken before and 1 hour after. The PF ratio has to improve the 20%. There is, if you want, I will circulate our protocol, but this is what clinically is used throughout the hospitals. So it's Mass General, Brigham Women's Hospital, Newton Wellesley. So all the area where our respiratory care team is clinically active.
Perfect.
Thank you for the question.
Using a 20% improvement, so reduction in case of pulmonary pressure or increasing in terms of PF, correct?
Correct. Yes.
At 1 hour. Very good.
Yes.
Very good.
Yeah.
Good.
If
Now,
it's not, then
question,
it comes off. If it's not positive, if there is not, then there are centers, different other centers that they use other pulmonary vasodilators, epoprostenol and so forth. So, but the test is always done on nitric oxide. And then the patient is either kept on nitric oxide or switched to epoprostenol or other pulmonary vasodilator according to the center.
Okay, so it's a test and bridge therapy to something else more definitive. Very good. There's another question on this topic, which is the following. You showed a clear dose-response relationship for selective pulmonary vasodilation, while no so clear dose-response in terms of VQ matching is straightforward, correct? How do you explain this discrepancy? And the other question which is related to this is about rebound hypoxemia or rebound pulmonary hypertension when INO is stopped. So is it true? How do you deal with it?
Yes, it's true. Let's start with the first question. So I think that so there are, of course, responders and non-responders to therapy, right? So let's start with the pulmonary hypertension. So usually nitric oxide is given for nitric oxide is given in, let's say, in cardiac surgery on pulmonary hypertension patients. And there will be like a 20-30% in a chronic pulmonary hypertension. There will be a 20-30% that is responders to nitric oxide. So in those patients, in those responders, the higher the concentration, you will see, we did so many testing and there is also lots of literature, it will be dose response, like there will be an increment of vasodilation according to the concentration of nitric oxide that is given. In addition, I think is what Ran just showed us now today is that one needed to consider also about the pulmonary condition of the patient. If a patient has, let's say, cystic fibrosis or chronic pulmonary disease, interstitial lung disease, with very little amount and mass of lung that is absorbing really the gas, there will be a very little response. So the concentration might be required, might be higher to obtain the same effect. So it's a complex topic. I think there is we started to finally understand the nuances of that. So I think that will be that is an area of expansion. The other thing that is instead is when to stop nitric oxide. So if there is the gas is let's start with a case of hypoxemia after nitric oxide is weaned. So that means that really the nitric oxide is doing what it should do, which is basically VQ matching. It means that basically the patient is not healed. Nitric oxide is let's say in that case is given as a rescue therapy, does not heal the lungs. So let's say if the patient has pneumonia, ARDS, and the patient returns to be hypoxic, means that the underlying condition ARDS is not solved. However, different story is instead the pulmonary hypertension rebound. So rebound pulmonary hypertension. In that case, is really basically is a dysfunction of the eNOS, nitric oxide synthetase of the individual, of the, let's say, the patient. And is more severe according to the amount of gas that is being used, the time of the gas that has been used. We never seen patients with pulmonary hypertension, rebound pulmonary hypertension after 20, 30, 40 minutes of nitric oxide, even when we give it 300 parts per million. In more than 1,000 therapies, we never seen that. We see instead in those patients with, for example, most critical are definitely the newborns. So newborns where basically the lungs is not completed, and so therefore also eNOS intrinsic, so nitric oxide synthetase of the baby is not completed or is not functional. And so then in those patients that are more at risk. Or again, the patients where they are prolonged, they are receiving for long days or weeks even nitric oxide, and therefore the nitric oxide endogenous nitric oxide synthetase is knocked down. So it will take time. So in those cases, what we recommend, what we do is we wean nitric oxide very slow. We wean nitric oxide at we go to 5 parts per million, and then we wean 1 part per million every 8 hours. And if there is a pulmonary hypertension, pulmonary vascular resistance goes up, then we stay for 12 hours or 24 hours, and then we restart the weaning at every 8 hours, 1 parts per million.
Thank you. Very interesting. So there was a lot of interest regarding the antibacterial use of inhaled nitric oxide. And in particular, so this is more of a philosophic and, how you envision the future of inhaled nitric oxide in the ICU in the future, because multi-resistant bugs are here and will be more and more a problem. You showed some incredible data. Do you think that this will be part of our clinical practice in the future?
So, I mean, there is a beautiful paper that, hold on, will come out, I hope, by Christmas from Binglan. You is hopefully with basically what she showed, that there are inhaled nitric oxide has an anti-pseudomonal effect. This is going to be a beautiful study. Results will come out soon, hopefully. And I think that what we need to do is we did a phase 1. So Giovanni Bruno did a phase 1 study in healthy volunteers at 300 parts per million. we are going to start a run. Dr. Dong is going to start a study on 300 parts per million, similar study. However, there will be patients intubated, so intubated and mechanically ventilated. So it's very important that we do now the safety studies. We are in the safety and early efficacy data in humans. However, we have been given high dose nitric oxide in those patients that, for example, when there was no therapies. At the beginning of, I show some of this data in COVID-19, as well as in pregnant patients, where basically there was no other therapy. In that case, there was under compassionate use or IRB studies, so that but definitely is an area of expansion. We are very excited. It's not only us. Now there are many centers that are actually starting trials on high dose. So I'm very happy that other centers, they are actually confirming some of our results. So it's in Israel. There is studies in babies with bronchiolitis. Studies in Brazil that are starting now. Australia, Russia. So there is several centers that are active on that. So it's
great. So staying on this topic, some questions came on the Courtney case. So the question was, how long did she actually receive inhaled NO therapy? So she did multiple runs, so to say, but how long does it last? And I think that we can put two questions together. What is the concentration in terms of ppm that can be reached with pulsed electrical discharge? So because you're talking about 300 ppms, high dose, can this be reached with your pulsed system?
Device. So I let Bingla answer to this question. How much can you produce with for example, with the pulse?
We can go quite high. So the slides I showed, the recent development of the devices. So the high pressure NO generator can go up to 200 ppm liter per minute, and then the gliding arc can go quite high, like 1,000 ppm.
All the way up to 10,000 parts per million per liter. So then, of course, you dilute, but there is enough for the entire world. So it's really, if you think about, the concentrate, there is oxygen, nitrogen in air, so you can actually produce as much as you want. So there is no limit in the production. So in fact, it's so simple. That's quite impressive. So ideally, there is no need for tanks in the future. So that, and then for the
go ahead.
The question for Courtney, you were asking. So we started, that was really the first time that we ever used nitric oxide. There is a beautiful video. I invite you to watch it. It's on YouTube. It's her story. She tells her story. It's so it's 30. We started with 30 minutes. We started with 15 minutes because we were, of course, very concerned. We started at 160 parts per million. She tolerated very well. She went to 200 parts per million. We just follow methemoglobin, and we make sure that nitrogen dioxide, which is really something that you really want to measure and to be careful that it's not gonna be high, because nitrogen dioxide, which I didn't present but it's a safety monitoring, because with oxygen and with water can form nitric acid. So nitric acid is a pH 1, so you don't want to have nitric acid in your lungs, especially when they are inflamed. So we needed to maintain nitrogen dioxide very low at high concentration of nitric oxide itself. So we make sure we went slowly up, and we reached up to 300 parts per million in 30-45 minutes, as long as she tolerated. We sometimes even went up to 1 hour, repeated doses to three times per day. And the first time that we tested and we used for her was like for 10 days in a row. And that when she was extremely sick, she was close to being intubated and so forth. But then the subsequent time, never more than, on average, 5 days. That's what we envision for the study that we wrote for the ICU patients, is a 5-day course. Of course, the patient is receiving the antibiotics that is receiving.
Okay. You said the word as long as she tolerated. Which were the causes to interrupt the treatment? Which were the symptoms that she could develop?
Yeah, for her, we never needed to interrupt. We had to interrupt in a healthy volunteer because couldn't tolerate the mask. So it was claustrophobic experience. In pregnant patients, we never had to interrupt, even though the patient was really at the extremely high concentration. The patient was very tachypnic, but we were able to maintain. We try to maintain methemoglobin below 10%, but most of the time is always below 5% in the clinical scenarios. In the healthy volunteers, we tolerate higher concentration. We went up to 10%, knowing that the level of hemoglobin is normal and knowing the patient is not hypoxic at baseline.
Yeah. So what you're saying is that you used methemoglobin both as a marker of nitric oxide uptake, but also as a safety limit because of oxygen delivery, especially if hemoglobin was low and oxygenation was low, correct?
Correct.
Very good.
Yes.
We have a lot of other questions. There is one about kidney function. And could you explain why, according to data, nitric oxide could be nephroprotective in cardiac surgery patients and seems to be harmful in ERDS patients?
Beautiful question. I started with the cardiac. So the cardiac patients is because there are multiple factors. Certainly, there is the standard properties of nitric oxide. Nitric oxide improves reduce pulmonary vascular resistance, improves right heart function, cardiac output, and so forth. But also, I try to show some of the data in terms of like reducing possible nephrotoxic effect of free hemoglobin. So when there is hemolysis, there is vasoconstriction, there is a reduction of pulmonary flow in the kidneys. There is a beautiful study that came out on anesthesiology few months ago from an Australian group that basically what they did was showing kidney perfusion and tissue oxygenation in the cortical and medulla of the kidneys in these animals, sheep, that were actually under cardiopulmonary bypass, showing that there's a reduction of TPO2, so tissue perfusion and tissue oxygenation in these kidneys that is the reason of the acute kidney injury. And so preventing and reduction or let's say maintaining tissue perfusion and oxygenation in those kidneys of those animals may prevent AKI. Now, of course, AKI during cardiac surgery, there is tons of other reasons for which one can have acute kidney injury. There is not only hemolysis, there is not only the cardiac output, there is multiple factors. So it's not that I'm saying that this is the only factor, but I think that there is areas where we can intervene. So the idea to give nitric oxide, we replace the depletion of nitric oxide in circulation. Therefore, we improve blood flow and oxygenation to the kidneys. That's the hypothesis that also we are testing in this very large randomized trial in China and Russia. The question about instead the nephrotoxicity in ARDS. So I think that there are I think there is a meta-analysis that they put together all the trials and all data showing that there is, in fact, an increase in nephrotoxicity in those patients that receive nitric oxide. I think it's always very hard to put together a meta-analysis when the trials have been done, as I tried to show you. They are done before ventilation was a standard, like lung protective ventilation was implemented, and when also there are, as we can try everything possible, but it's very complex when we add data that are not coming from randomized clinical trials and try to match patient population. That's what led to this literature. What I know is that based on our studies, also the most recent trial in patients with COVID ARDS, we didn't see any sign of increased renal nephrotoxicity. There is a possible, biologically, one could think that in sepsis, in septic shock, eNOS is overexpressed. There is a lot of nitrite that is produced. And that's the reason why in these patients, one can even think to give methylene blue. So the idea is to actually block eNOS production of nitric oxide. So there is an overexpression over. So the idea, one could say, if we give another exogenous amount of nitric oxide, can we actually impair the kidneys? It's theoretical. Nobody demonstrated that. So I think that for what we know, I mean, more than 1 million children receive nitric oxide, and none of them showed that there was a kidney or renal impairment. Certainly in cardiac surgery, there is not. If anything, there is a reduction. In ICU, I think there is lots of. It's hard to understand. I think there is the need of new studies and new randomized trials.
Thank you. There are two questions that we'll try to put together about the use of inhaled nitric oxide during surgery, so in the operating room. One asks if it is reasonable to think about using nitric oxide in elective surgery in case of pulmonary hypertension, and in case how it should be delivered. And the other one asks if there is any experience or evidence about the use of nitric oxide in lung surgery. So if this could somehow improve the function, reduce postoperative complications, or even postoperative pneumonia.
I started from the last one. There is a study that just was published by Nikolai and the group from Russia that is showing that there is a reduction of pneumonias and in cardiac surgical patients, post-operative pneumonias. I think it's still small. It's still let's say phase 2 study, but there is that study that's I think is the first study in post-operative pneumonias. And nitric oxide has been used. We are using after after lung transplants, mostly really for the right heart function and to So, but I think it's an area totally an area of research. There is not really lots of data there. There was a study, early studies in early 2000s that they showed that there was a reduction in interleukin-6 in the BAL in those patients that had the lung surgeries with nitric oxide versus controls, but still very scarce data. But one could hypothesize, but the study needs to be done. Then the other question, what was it? It was an intraoperative use of nitric oxide for?
the intraoperative in pulmonary hypertension or in elective lung surgery?
Yeah, we do. We use it. So we normally use, so the anesthesiologist request both for cardiac, for thoracic surgery, for lung surgery, or patients with a really terrible high pulmonary vascular resistance and pulmonary hypertension. We do use it. We just had a patient that came overnight with interstitial lung disease, with pulmonary hypertension, that was already on pulmonary hypertension drugs, that came with a abdominal obstruction, and we placed her on nitric oxide. She actually improved quite a lot intraoperatively, and then came to the ICU. Eventually, we extubated on high flow on nitric oxide, and then bridge it to other PD5 inhibitors.
Okay. There's another question about the possible use of nitric oxide in right ventricular cardiogenic shock, so right ventricular failure, for example, amniotic or cement pulmonary embolism, or other conditions of right ventricular failure. Do you have an experience? Is there any data out there to help us in this difficult scenario?
Yes, there is again. I think there is more like a case reports or very small studies here and there. So I think that it's a very much of the area. It makes sense, right? If you have a right heart constraints, so then was pulmonary embolism. But again, it's not the therapy, it's not the treatment. And so I guess that one really need to fix. So you can improve some symptoms, but definitely it's a bridge to a definitive therapy. I think that, you know, if there is no VQ mismatch, if the patient is not hypoxic, one therapy that is really simple to do even before surgery is to give sildenafil. You give sildenafil and you go into surgery. That's what I was doing when I was a resident, so it works well, and it's very simple to do and deliver. I think until the machine of Bingla is ready and is easy to implement, it's not so simple, of course, to put tanks and so on. So when a patient is not hypoxic, because if you give sildenafil to a patient that is hypoxic, of course, what happens is that there is an increase in a VQ mismatch. So there is a deterioration of hypoxemia. That's the reason why we don't give sildenafil in patients with ARDS. That would be something that would be a killer. But we can give it when there is only pulmonary hypertension.
Okay, the last two questions. One is mine. I just Googled and I saw that when you smoke a cigarette, of course you shouldn't, there is quite a lot of nitric oxide. So I read, I don't know if it's correct, that it can be as high as 300 parts per million. So can we say that giving inhaled nitric oxide is just like taking the good part of smoking?
Yes, of course, yes.
All right.
It's combustion, right? So it's a nitrogen and oxygen. Exactly what Bingla showed before. Is exactly how to produce nitric oxide. In fact, the reason why, that's historically, the reason why the first study were conducted at 20 parts per million. Why do we use 20 parts per million? Because at the beginning, when before the nitric oxide became a therapy, it was, of course, a poisoning gas. The FDA, and actually, let's call it the EPA, the Environmental Protection Agency, there was a regulation that one could not, if it was a worker in, for example, in McDonald's, frying pans and burger and flipping burgers, one worker should not breathe for more than 8 hours, more than 25 parts per million. Then Zapol said, okay, here it is the rule. Let's give it 20 parts per million to these newborns. And so then became FDA approved 20 parts of nitric oxide for that reason. So yes, so I guess we breathe nitric oxide every time we go on the street. Combustion produce nitric oxide, but of course, it's very labile, so it doesn't transform in any other compounds, nitric oxide compounds.
If I remember, I'm sorry, Thomas, I think
But-
our common chief, Luciano, was talking about this effect a long time ago when he smoked a lot to say, and there is benefit effect on vasodilation and so on. So it's a well-known story about the positive effect of smoking. Sorry to be joking, but we all remember the story.
Yes.
Sorry.
In fact, I don't know. It's good because he always said that. They always said, "Oh, a nice cigarette after lunch or after dinner is improving my perfusion in my gut." So,
He always said also that the brain could benefit or more ideas because of vasodilation and the positive effect of brain perfusion.
Hopefully, it's not the nicotine part.
yeah.
I think it's also we learn from the smoking. We can give high dose and intermittently, not continuously. So without causing methemoglobinemia.
Great. So the last question is just inspirational, and then I will give the stage to Pietro to close the webinar. Is about we are looking up to you as scientists, as clinicians, and we're looking up to the MGH and to Harvard. How is it there, and why should our residents or our physicians come to you to study and to learn to do good science and good medicine?
Well, let ask this question will be, I would say, ask to the fellows that have been here. So I think there are lots of people that are there, that including Pietro. So I think that there will be much less bias than me. So you can. No, I came here by the way. I came here because there was a person that invited me, and I had a great esteem. That was Warren Zapol. And when I discussed that when I was a resident with Antonio Pesenti, that was my chief when I was in Monza, he said you should go. He's a great guy. I liked him. Kolobov, that was my mentor in Washington D.C., told me you should go if you wanted to learn about anesthesia and critical care. You want to do research. You should stay with him. I came and I was thinking to come here for a few years, and I never left. But I guess, I guess it then becomes a personal story that needs to be. But I think that for nowadays, of course, this presentation is recorded, so I can tell you more by phone.
All right. Thanks a lot, Lorenzo, Bingla, and Anna. Really, it has been for me an exceptional, an outstanding presentation. And I think that Lorenzo, you have showed us really a journey, as you mentioned at the beginning, including biology, experimental research, clinical research, which to me it's really fascinating. I think it assembled a lot the journey of Warren Zapol, as we know that very well. And I think that this is a real model of how research is and should be, really including, cells, biology, going back to clinical questions, and then going back again in experimental laboratory research and translating the results up to the clinical treatment of our patients. And really, this is, to me, it's really extremely fascinating. So thank you very much for this example. For everybody, the next webinar will be, I think, the 22nd of January, right, Tom? As far as I remember. We don't know yet the topic, but we are working on that. So we will announce that very soon. And for everybody, we will have the recording of this wonderful webinar on our YouTube channel quite soon, I guess. So thank you very much again to everybody, and see you very soon. Ciao,
Thank you.
Lorenzo.
Bye-bye. Bye-bye.
Thank you so much.
Bye.
Bye.
Bye to everybody. Ciao, Luca.
Thank you. Bye
Ciao,
bye.
Giovanni.
Ciao, ciao. Ciao, Lorenzo.
Ciao, bye. Grazie.